Hello, and welcome to today's webcast where we will be covering the Diagnostic Challenges of Bordetella pertussis. My name is Sarah Lewis, Communications Manager at Meridian Bioscience, and I will be your moderator for today's event. During the presentation, you will be able to submit questions. Click the green Q&A icon in the lower left-hand corner of your screen. Type your question in the open area and click Submit. Questions will be answered at the end of the presentation in the order that they are received. A few housekeeping notes we would like to mention. If you would like to view the presentation in a full screen view, click the full screen button in the lower right-hand corner of your screen. Press the Escape key on your keyboard to return to your original view. For best results in viewing this presentation, we suggest you turn off pop-up blockers and disable instant messaging programs to improve computer performance. If you are experiencing any difficulty with the audio portion of this webcast, we recommend using a wired, high-speed internet connection, as wireless connections can be unpredictable. And finally, should you need technical assistance, as a best practice, we suggest you first refresh your browser. If that does not resolve the issue, please click on the support option in the upper right-hand corner of your screen for online troubleshooting. It is now my pleasure to introduce today's program. The Diagnostic Challenges of Bordetella pertussis will provide a comprehensive overview of Bordetella pertussis and the benefits of molecular detection with illumigene. I would now like to introduce today's speaker, Dr. Susan Sharp, the Director of Regional Microbiology and Molecular Infectious Disease Laboratories at Kaiser Permanente in Portland, Oregon. At this time, it is my pleasure to turn today's program over to Dr. Sharp.
Thank you very much, Sarah, and good morning or afternoon, everyone. I'd like to first thank Meridian Bioscience for asking me to join you all today and giving this WebEx. And thank you all for joining in today for the next hour to talk about pertussis. And you'll see that I named the title of the seminar, What's Old is New Again. And that's because in the early to the mid-1900s, we had very high levels of pertussis in this country and worldwide. With the advent of vaccination, these levels dropped very, very low in the 1960s until about the 2000s. So until about 10 years ago, levels of pertussis again started to rise, and we find ourselves back to levels of pertussis that we have not seen since the 1930s before the advent of vaccination. So let's go ahead and get started. Today we're going to cover the disease of pertussis causes, the prevalence of the disease, the treatments that are available, how we can diagnose this infection, and then some testing that we do here at Kaiser Permanente in the Northwest. So let's talk about Bordetella pertussis first, the organism. We know that Bordetella is a fastidious, aerobic, slow-growing, small gram-negative bacilli. It is oxidase positive. It can often take up to 6 days, 3 to 6 days, in order to form visible colonies on specialized media that we have to grow the organism on. Now, Bordetella pertussis produces multiple antigenic and biologic active products. And these products include pertussis toxin, filamentous hemagglutinin, adenylate cyclase, pertactin, which I'll talk a bit about more in a second, and something called tracheal cytotoxin. It's these products that are responsible for the clinical features of pertussis disease, which we know as whooping cough. Now, pertactin I mentioned as one of the virulence factors for Bordetella pertussis, and pertactin is a highly immunogenic virulence factor of this organism. Specifically, its function is that it is an outer membrane protein of the organism that promotes adhesion of the organisms to the tracheal epithelial cells. And a purification of pertactin is actually used in vaccine production as one of the components of the acellular pertussis vaccine. Now, we know that whooping cough caused by Bordetella pertussis is very highly contagious. We know it's found only in humans. There are no animal reservoirs for this disease. Whooping cough is spread from person to person, either by close contact, from airborne droplets, and from coughing and sneezing. And it's even been reported to have been spread from person to person through singing. Now, we know that one of our most susceptible populations are the infants who can become ill with whooping cough, and they are normally infected by older siblings or parents or other caregivers who may not even know that they have pertussis. And we'll talk about that a little more when we get to the signs and symptoms of pertussis. The incubation period for pertussis is on an average of 9 to 10 days, so a week to a week and a half, but it can range from as soon as 6 days up to 20 days after exposure to someone with the disease. Pertussis is characterized by 3 phases of illness that are known as the catarrhal stage, the paroxysmal stage, and the convalescent stage. Now, it's interesting to note the disease may not always present itself with these classic symptom likes. For example, the primary stage of pertussis may be very insidious in onset, can be very similar to the common cold with nonspecific cough. These symptoms may be indistinguishable from other respiratory illnesses. So again, early on, whooping cough and Bordetella pertussis infection can be very difficult to diagnose. Here you can see the 3 phases of pertussis infection. The catarrhal stage, again, which is the first stage, can last from 1 to 2 weeks, and again, show those nonspecific symptoms of runny nose, perhaps a low-grade fever, a mild and an occasional cough, and again, is very highly contagious at this catarrhal stage. Stage 2 is the paroxysmal stage, and this can last from 1 to 6 weeks and can even last up to 10 weeks and sometimes longer. Symptoms associated with the paroxysmal stage is where we see those numerous rapid coughing fits followed by the whoop sound of inspiration after one of these coughing fits when you can finally breathe again. These coughing fits, that's why this stage is called the paroxysmal stage, because these coughing fits are called paroxysms. And these coughing fits can lead to vomiting and exhaustion after these coughing fits. They can be quite pronounced. And again, this can last for up to 10 weeks. And the third stage of pertussis infection is the convalescent stage. Now, this lasts about 2 to 3 weeks. And at this stage, after going through this much, 10 to 12 weeks of sickness, the patient is also very susceptible to other respiratory infections they might come into contact with. During the convalescent stage, recovery is very gradual. Cough will lessen, but there are still several bouts of this coughing fit that can return on some occasions during the convalescent stage. Now, we know vaccination is very important for the control of pertussis disease. We also know that vaccination or even immunity from infection, if you've had pertussis, is not lifelong. We know that vaccine provides a high level of protection for the first 2 years or 3 years after vaccination. And we know that active infection itself will only actually protect a person for a few years. That combined with knowing that pertussis vaccines are about 80 to 90% effective, we know we have waning immunity with pertussis. Hence, the CDC vaccination recommendations based on age for pertussis and whooping cough. You can see on this slide that the CDC recommendations for infants less than 6 months of age is for DTaP. DTaP is the pediatric diphtheria, tetanus, acellular pertussis vaccine dose, and it is recommended at ages 2 months, 4 months, 6 months, and then again between 15 and 18 months, and then again before the child would start school at ages 4 to 6. At ages 7 to 10 years of age, DTaP, which is a tetanus, diphtheria, acellular pertussis vaccine, and this is a slightly weakened version of the pediatric pertussis vaccine. The DTaP is recommended for children ages 7 to 10 who have not been fully vaccinated against pertussis, looking at the schedule above. They recommend a single dose of DTaP for those that are not fully immunized, or an additional dose of tetanus and diphtheria toxoid-containing vaccines are needed, then the child should be vaccinated according to the CDC catch-up schedule, which you can find on the CDC webpage. And it is preferred at that point that DTaP would be the first choice rather than just vaccinating to tetanus and diphtheria. Through ages 11 to 18, again, DTaP is what's routinely recommended in a single dose between 18 and 11, preferably with administration at the younger end of that age scale, preferably between 11 and 12 years of age. Now, if not fully vaccinated as a child, again, there's a catch-up schedule that can be adhered to. And if the patient did not get DTaP at 11 to 12 years of age, they should administer the DTaP vaccination at the next patient encounter or sooner, especially if the adolescent is going to have contact with infants. Now, any adult who has not received a dose of DTaP should get one as soon as possible to protect themselves and also to protect any infants that they may be around. Now, this DTaP booster can be given in place of one of the 10-year diphtheria tetanus vaccine boosters. Again, as I alluded to in the title of the slide, the outbreaks of pertussis were first described in the 16th century, and the organism was first isolated in 1906. There's an estimated 16 million cases of pertussis every year and almost 200,000 deaths worldwide due to this disease. And as you can see in the graph on the screen, again, we're seeing activity now since 2012 that we have not seen since before the advent of vaccination in the 1930s. There have been in 2014, there were 33,000 cases of pertussis that were reported from the United States to the CDC. And this was a 15% increase compared to the year before in 2013. And Oregon, which is where I am located, contributed more than 400 of those cases in 2014. So a little over 1% of those cases came from Oregon. And you can see by the graph on the slide that when you look at the incidence of pertussis from the 1990s up into 2014 by age group, that indeed it is our youngest population, those children less than 1 year of age that are at most risk for contracting pertussis. Now, as far as treatment for pertussis goes, we know that younger children and infants are typically hospitalized when they have whooping cough, again, because it is much more dangerous for that very young age group. Older children and adults can usually be managed at home without hospitalization. Now, for treatment and also for post-exposure prophylaxis, for those people that come into contact with someone that may have pertussis, if the patient is 1 month of age or greater, a macrolide is recommended, either azithromycin, erythromycin, or clarithromycin. For neonates that are less than 1 month of age, azithromycin is preferred, again, for treatment as well as post-exposure prophylaxis. If an alternative to a macrolide is needed, if the patient is 2 months of age or greater, that alternative is trimethoprim sulfamethoxazole, again, for treatment and post-exposure prophylaxis. Now, the timing of treatment is important. Early treatment is very important for adequate treatment of Bordetella pertussis and whooping cough. It's known that antibiotics started during the first 1 to 2 weeks. That's before the paroxysms of the coughing start to occur, that we can actually lessen symptoms. So again, if antibiotics are started early in the course of disease, preferably in the first 2 weeks of disease before we get to the paroxysmal stage, and slightly into the paroxysmal stage, we know that we can lessen the symptoms associated with the disease for the patient. However, if the patient is diagnosed late, antibiotics will oftentimes not alter the course of their illness. So again, if we're going to have a chance to, excuse me, make the patient feel better, decrease the symptomologies associated with this disease, the sooner that we can get an accurate diagnosis and treat the patient appropriately, the greater chance we have of actually altering the course of the illness for the patient. Now, keep in mind, people are contagious from the beginning of the catarrhal stage, which is the first stage, where they have just the nonspecific symptoms of a runny nose, sneezing, maybe a low-grade fever. They are contagious through the 3rd week after onset of the coughing fits. So basically, for the first 5 weeks or so, a patient can be contagious for spreading whooping cough and Bordetella pertussis, and or until after 5 days of starting antibiotics. So after 5 days of starting appropriate antibiotics, the patient should no longer be contagious. But again, there's a long window where people can be contagious if they're not diagnosed appropriately and rapidly and not treated appropriately and rapidly. Complications seen in pertussis, mostly among adolescents and adults, include sleep disturbances, incontinence, rib fractures, again from that horrendous coughing during the paroxysmal stage, and they are open to secondary bacterial and viral infections that might cause pneumonia. Now, we know that pertussis is most severe in our infant population, with 57% of patients that are less than 1 year old will be hospitalized. This is due primarily to the complications that can happen in infants, which include, again, pneumonia, seizures, encephalopathy, hernia, subdural bleeding, and conjunctival bleeding. So again, our youngest populations are the ones most at risk for severe disease with pertussis. Now, we do have a lot of diagnostic challenges when we look at trying to diagnose whooping cough or Bordetella pertussis in the laboratory. And these include the range of sensitivity of the different tests that can be performed. It's important to know what stage of disease that the patient is in, because that will have an effect of whether or not we're able to diagnose pertussis, depending on what test system we're using for that diagnosis. It's important for antimicrobial administration to make an appropriate diagnostic. It's also important to know if you have an actual case of pertussis, because it will affect the vaccination schedule going forward for the patient. So it's also important to know their previous vaccination history as well. Specimen quality is very important for detecting and being able to detect Bordetella pertussis, and of course, turnaround time is also very important. We'll talk about all of these when we talk about our diagnostic challenges with diagnosing pertussis. Now, the gold standard for pertussis laboratory diagnosis has been culture, and we'll talk about that on the next slide. We know that we have new molecular techniques for diagnosing pertussis, and we'll talk a little bit more about that as well. But let me say a few words about serology before we go forward. Serology can confirm late illness in late course of the disease, but it is not going to help you diagnose a early onset case of Bordetella pertussis. And the standard direct fluorescent antibody test, the DFA test, we know now has a very low sensitivity with a variable specificity, and CDC now states that the direct fluorescent antibody test should not be used for laboratory confirmation of pertussis testing. So let's talk about culture, Bordetella pertussis culture. Isolation rates will be highest during the first 2 weeks of illness. So if you're going to do culture, the best chance you have of being able to isolate the organism is in the first 2 weeks during that catarrhal stage, and maybe even into the early paroxysmal stage of disease. We know cultures have variable positivity rates, as low as 30 and only about as high as about 50-some%. We know cultures can take a long time to, since it is a slow-growing organism, it can take up to 2 weeks or more to be able to isolate the organism and appropriately identify it. So with culture, results may actually be too late for clinical usefulness. It may actually, you might get a positive result from culture, but if it made too late, again, to give appropriate therapy to where you're going to lessen the symptomology for the patient. And we also have to keep in mind that a negative result from culture does not necessarily rule out pertussis infection, so since we know that the culture positivity rate may only be as high as 50%. Again, cultures are much less likely to be positive if they're performed later in the course of illness. So more than 2 to 3 weeks after cough onset. So during the mid to the late part of the paroxysmal stage and into the convalescent stage, you're much less likely to get a positive culture. Or if you're doing a culture from a person who has either received appropriate antibiotics or patients that have been previously vaccinated, you're less likely to get a positive culture result. And again, since adults and adolescents oftentimes have been coughing for several weeks and are way into their convalescent phase of the disease before they seek medical attention, it's, again, often too late to try to do a culture, because a culture will be not very useful at that point. And we have to also note, again, due to the variable positivity rate of culture, that using culture alone is oftentimes going to lead to an underreporting of true Bordetella pertussis cases. Now with molecular testing, we know we have molecular testing out there now that are highly sensitive. They do have a much more rapid turnaround time than culture if they're performed daily. They're ideal for the rapid diagnosis of pertussis and whooping cough, and unlike culture, molecular assays do not require a viable organism for detection of positive results. Molecular testing is currently recommended by the CDC, the Infectious Disease Society of America, as well as the American Academy of Pediatrics. And the CDC will tell us, though, however, in an outbreak situation, that culture should be used at least in a few patients to confirm the diagnosis from your PCR testing. Again, not on all samples, but on a sample of all the patients coming in with positive PCRs. You should try to confirm some of those with culture to indeed make sure we are dealing with an outbreak of pertussis. Now, pertussis for laboratory testing, you can see here, I've shown you a timeline of what the optimal testing for diagnosis is in weeks. You can see where the cough onset is. Culture, again, will be positive during the first 2 weeks, maybe into the 3rd week. Molecular testing will be positive out to 4 weeks of testing. And then again, serological testing can be helpful later in disease in order to document infection, but again, will not help you early on with diagnosing Bordetella pertussis infection. Now, in the past, at Kaiser in the Northwest, up here in Portland, Oregon, all of our pertussis specimens were collected in Reagan-Low media, and they were sent to our Oregon Public Health, State Public Health Laboratory. At the Public Health Laboratory, they would do DFA and culture. And we know that the turnaround time is not effective for patient care, certainly not for treatment of the patient to try to lessen their symptoms, and certainly not for case contact controls as well, which need to be prophylaxed. Now, our Portland State Laboratory did switch from DFA to PCR testing over the last several years. As of February 2015 of last year, so about a year ago, we implemented the illumigene platform. This was the first FDA-cleared and standalone molecular assay for pertussis. It's a simple assay. It has a reasonable cost, and we do our testing daily with a turnaround time within 1 day. And the testing time in our hands from start to finish takes about an hour and a half hands-on time to do multiple specimens. And this is the Meridian illumigene pertussis assay instrumentation. At Kaiser in the Northwest, we do perform this testing, as I said, 7 days a week. Once per day, we do batch the testing and perform it once a day. We do run positive and negative QC each day of our patient testing. So this allows us that we do not need to develop an IQCP program for this testing, since we're doing our positive negative QC testing each day of patient testing. And we basically, depending on what's going on in the state and if we're in some kind of an outbreak situation, we can probably do run the test every day. Now, as far as acceptable control materials, there's a variety of acceptable control materials you can do in order to do your QC testing. There's the illumigene pertussis external control kit that you can get from the manufacturer. You can also use positive and negative patient samples that have been previously tested on the assay. You can also use ATCC control strains. And what we do is we use 50 microliters of our control strains that we've made up into a 0.5 McFarland suspension in molecular grade water. And for the positive control, we use a Bordetella pertussis ATCC strain. And for our negative control, we use a Bordetella parapertussis ATCC strain. Now, there are a couple of limitations associated with the illumigene pertussis platform. We have to keep in mind that Bordetella parapertussis, which does cause a pertussis-like illness, will not be detected by the illumigene pertussis assay. As I indicated above, our negative control is actually a Bordetella parapertussis. Now, illness caused by Bordetella parapertussis can cause a pertussis-like illness, although it is generally a more mild disease. And this is primarily because the Bordetella parapertussis bacteria do not produce the pertussis toxin. The illumigene PCR assay does target the IS481 insertional element of the Bordetella genome. Now, this IS481 insertional element is present in high copy numbers in Bordetella pertussis, and in lower numbers in both Bordetella holmesii and also in some strains of Bordetella bronchoseptica. Now, we know Bordetella bronchoseptica is a very rare event in humans. It does happen, but it's very rare. So it could potentially be detected by this assay. Bordetella holmesii is probably more common in humans, although it's not nearly as common as Bordetella pertussis. And keep in mind, with both Bordetella holmesii and Bordetella bronchoseptica, the insertional element IS481 is found in much, much lower copy numbers. However, because of this limitation, we do report out a disclaimer with our assays that says rarely positive results may be related to the presence of either Bordetella holmesii or Bordetella bronchoseptica. So let's talk a little bit about the illumigene pertussis assay. Again, as I said, it's the first FDA-cleared standalone molecular assay for the diagnosis of Bordetella pertussis. This is the steps utilized in the assay, and I'll go over those in a second. The package insert performance specification states that this assay has a sensitivity of about 88% and a specificity of about 98% with results in 1 hour. Again, in our hand, we batch our testing assays and as well as run a positive negative control every day. So with our batch of about 8 to 10 samples, again, including our controls, our turnaround time from start to finish is about 1.5 hours. Now, the assay is done by, you do a sample collection of a nasopharyngeal sample. You insert the swab into the sample buffer and break off the end of the swab, and this is vortexed. You then transfer 50 microliters of this sample into the assay control tube, and it's vortexed for 10 minutes. That is a tube that then goes into your incubator for incubation for about 40 to 45 minutes. After that point, you take the sample and you transfer 50 microliters into the test and the control chambers of the illumigene test device. You add oil, mineral oil to the top. Tap it to make sure that all the bubbles are gone, and then you stick it on the instrument you stick it on the instrument. That's when it incubates for about 40 minutes, and then it'll give you an answer to the assay. So again, very simple procedure to use, FDA cleared, very good sensitivity and specificity performance. I will also like to mention that the illumigene pertussis platform is now cleared for use with eSwabs as well. This eSwabs were FDA cleared for use in this platform in November of 2015. And again, depending on how many tests you're running, you can have results in less than 1 hour. Now, I wanted to briefly review a poster that was presented at the ASM General Meeting in 2013 that was done at the Medical College of Wisconsin. And in this assay, they evaluated the illumigene pertussis nucleic acid testing platform and compared it to a Cepheid ASR assay, analyte-specific reagent assay. You can see that the sensitivity of the illumigene pertussis platform was about a little over 97% compared to the Cepheid ASR assay with a sensitivity of 100%. Specificity of the illumigene was 97.6% compared to the Cepheid ASR, which had a specificity of 93.6%. The other thing this poster evaluated was also the pertussis call rate. And this is based on the initial assay results and then repeating any invalids a second time to try to get an answer. When they looked at the initial call rate, where they got an answer at the very beginning, 98% of the samples out of their 410, 402 or 98% gave them a call at the first time run. In this poster, they had to retest 8 samples, which originally gave an invalid result, and 7 of those 8 gave a call on the second testing. So for their final call rate out of the 410 specimens, a total of 409 with only 8 happened to be repeated, gave them a percent call rate of 99.8%. So this poster concluded that this assay has greater than 97% sensitivity and is specific for the detection of Bordetella pertussis from nasopharyngeal swab samples, that the platform is more specific than conventional PCR when the CT value of 35 is used as a breakpoint for true infection, that the illumigene pertussis assay has initial call rate of 98% and a final call rate of over 99.8%, and that their lab technology, using their isothermic amplification for the detection of Bordetella pertussis, on samples takes about 45 minutes and allows for a very rapid result. Based on reviewing this poster, I wanted to look at what our call rate was. So we did look at our call rate for last year. We looked at our samples we started the assay in February and we're full-blown testing in March. So we looked at our data from March to the end of December of last year. We tested a total of a little over 1,000 samples. Of these 1,000 samples, we had to repeat 56 of them that gave an invalid result, so we repeated about 5.5% of those samples. Of those 56 samples, 26 or 46% resolved with an interpretation. 30 of those 56 samples, or 54%, gave us a second invalid result. So we had an initial call rate of 94.5% with a final call rate of 97%, which again we feel is very acceptable for this rapid molecular-based assay. And I'd like to finish off today with a couple of cases. This is a case from Kaiser with a 6-year-old girl who was seen in our clinic with a 3-day history of a runny nose, some red puffy eyes, a low-grade fever, and intermittent coughing. So again, very nonspecific symptoms coming in from the 6-year-old little girl that was brought into the clinic. Her temperature was 38, so slightly elevated. Her respiratory rate was also slightly elevated. Physical examination also showed rhinorrhea, so runny nose, some conjunctivitis, some sporadic coughing. The patient was slightly dehydrated and seemed to be under a moderate amount of stress. We did obtain some patient history from the mother. The mother herself had undergone some coryza-like symptoms or head cold type of symptoms, followed by a cough. And the mother did say that her cough was pretty severe and lasted for a long time. And she had it for about 3 months, a couple of months before and about a month after she had her second child. So our patient actually had a baby brother born about 3 weeks previous to this patient becoming ill. Should be of note that it was also found that the mother and the 6-year-old had not been vaccinated to pertussis. At that point, an NP swab was collected from the child. Now, again, we said that specimen collection is very important for the accurate diagnosis of pertussis. It is important that you actually sample the posterior nasopharynx. And here you can see an NP swab. This is a pediatric NP swab that has a little stop. You can see where the circle is halfway up the swab, which will actually stop the swab at the end of the nose, but allow for the end of the flock swab to reach the back of the posterior nasopharynx, as shown in this slide. Again, taking a sample from the nasal passages or the throat is not appropriate. It should be an adequately collected sample from the posterior nasopharynx, as showed here. Here you can see a young child. Again, you can see that they're using this pediatric nasopharyngeal swab in order to accurately obtain the appropriate specimen for testing. Now, here in the Northwest, before we started molecular testing, our physician choices were to collect a sample, and it would go for testing at our Oregon State Laboratory. And initially, that was for culture and for DFA for years. At this point, if pertussis was not highly suspected, and when someone has very nonspecific symptoms, like we talked about, can happen at the initial outset of symptomology with pertussis, oftentimes amoxicillin and perhaps some coughing medicine with Tylenol may be given to the child. The physician or clinician could collect a specimen, send it in for routine culture, sometimes for pertussis testing. But again, knowing that the results for the pertussis testing would not be back for a minimum of 5 to 7 days, oftentimes antibiotics would be given out until they found exactly what was going on with the patient. This potentially exposes the child to incorrect antibiotics if pertussis is not suspected, and obviously increases the expense to both the family and the pharmacy. After we brought molecular testing in-house last year in February on the illumigene platform, our physicians now wait for the result of the pertussis. Now that they know they're going to get a result within a day, within 24 hours, they will wait on antibiotics prescribing on these patients if they're not in severe distress. They'll wait that 24 hours for the result of the molecular testing for PCR for pertussis. This saves the patient exposure to unneeded antibiotics and makes sure that the appropriate antibiotics are given. This will save the patient money, it saves pharmacy costs. And also, we know that we need to give appropriate antibiotics within the first 24 to 36 hours of the clinic visit, that we can, again, if we hit that 2-week period of giving the appropriate antibiotic therapy, we know we can actually lessen the symptomology for the patient. Now, it is important, as I mentioned earlier, to make sure that we do have laboratory-confirmed cases of pertussis. Knowing that the illness is actually confirmed to be pertussis is important because it impacts several different issues. It impacts whether the child gets any more pertussis vaccine doses. Again, if they've had a live infection, they can probably go several years without a booster. That saves the patient and the pharmacy money. It's also infection control issues with our community that are very important. Keeping in mind that we do have to make sure we have appropriate post-exposure prophylaxis for any at-home contacts of the patient that has the laboratory-confirmed pertussis, as well as any school and daycare contacts, et cetera. As we know, community outbreaks are unfortunately very common with pertussis. So it's important to get to these patients and treat them appropriately. We know they cease to be infective after 5 days of appropriate antimicrobial therapy. So back to our case and our 6-year-old little girl. Antibiotics were not started immediately. The positive PCR results were back within 24 hours. We actually had those results back and called the physician within 16 hours after it was collected in the patient. Azithromycin was given to the child, and the mother was given information on appropriate pertussis vaccination, not only for herself, but for her family as well. Now, I want to briefly go over another case. This was not a case that was seen here, but a case given to me by a colleague. And this was in an infant, a 4-week-old infant who had a normal delivery, but was admitted to the hospital with 1-day history of gagging, gasping, vomiting. He was periodically turning blue and was having spells of apnea, or not breathing appropriately. Upon physical examination, his temperature was elevated, his respiratory rate was elevated. They could hear fine crackles in both of the infant's lungs. He was gagging and turning cyanotic from the lack of breathing appropriately. IV ampicillin and gentamicin were started in this infant, as well as oxygen supplementation. The child continued, unfortunately, to deteriorate within 12 hours and was transferred to acute care hospital. At this point, at the acute care hospital, the blood gases were all abnormal. White blood cell count was elevated with 40% lymphocytes and 42% neutrophils. Blood cultures, spinal fluid culture, and urine culture were all no growth. The child initially had 1 week of intubation, but his symptoms continued. They did a new chest x-ray, and at that time it was found that he had, a new collapse in his right upper quadrant of his lung. Now, under investigation a little bit more and talking with the mother, it was found out that the mother took this infant along with her 5-year-old to a neighborhood birthday party. At the party, the mother said that there was one girl that seemed to have a cold. She was sniffing and coughing periodically. And she said she tried to keep the baby away from the older children, but the little 5- and 6-year-old girls were just all over him. They just loved the little infant being there. So pertussis was suspected. It was tested and diagnosed within 24 hours using a molecular assay. The patient and the contacts at the party were appropriately treated with a macrolide. The patient did end up having 6 weeks of intubation before they were actually able to extubate the infant. His gagging, coughing, and apneic spells, however, did resolve, but it took them 4 months to do so, and the infant was hospitalized for a total of 3 months. Again, our most youngest populations are the ones that suffer the most from this disease. Complications in infants. We know pertussis can cause very serious and life-threatening potential complications in infants and young children who are not fully vaccinated. That's why vaccination is so important. Infants less than 12 months of age, about half of those infants will be hospitalized with severe disease. And of the infants who are hospitalized, approximately 61% will have apnea, 23% will develop pneumonia, over 1% will have seizures, up to 1% will actually die in the hospital from their infection. And about 0.3% can develop encephalopathy. Other complications listed there on the slide for you can include anorexia, dehydration, difficulty sleeping, hernias, again from the coughing fits, otitis media, and urinary incontinence. And again, as well as deaths. The more severe complications can include a refractory pulmonary hypertension, pneumothorax, rectal prolapse, and subdural hematomas. So in summary, pertussis remains a major public health problem, that has started to rebound and surge again over the last 10 years. Pertussis is a very serious disease that we know can happen sporadically as well as happen in outbreak situations. And again, as I stated previously, the infants are our most vulnerable population to this disease. They are the ones that suffer the most from debilitating disease, end up being hospitalized, and unfortunately, they usually get this infection from an adolescent or from an adult. Control of pertussis is very important, and there's two ways we can help control pertussis. One, primarily, is through that of vaccination. It's the very most important part of helping control this disease. And also, rapid diagnostics can also save the patient from inappropriate therapy, can improve contact prophylaxis, and also, if we can improve our contact prophylaxis, make sure we get patients on the right therapy as soon as possible in disease, we can decrease the transmission. And now we know that we have molecular assays that have very good turnaround times. They are simple to use. They're at a reasonable cost, and we know that they have very good sensitivity and specificity. So with that, I will thank you all very much for your attention today. I appreciate everyone calling in and listening to the webinar today, and I will turn it back over to Sarah for any questions. Thank you.
Thank you, Dr. Sharp, for a very informative presentation. It is now time for our question and answer session. If you would like a question answered, please feel free to click the Q&A button on the lower left-hand corner of your screen. Type your question in the open area and click Ask to submit. So we do have a question here. Why have you chosen to perform these in batch instead of as samples arrive in your laboratory?
Thank you for the question. That's a good question. Again, the assay that we're doing, we could do it as a reach laboratory. We're actually in an off-site laboratory. This testing is not performed at our clinics or in our 2 hospitals here in the Northwest, but it has been centralized to our off-site laboratory at the regional laboratory. It certainly is something, and people may decide they want to do this testing in-house, especially for those infants that are severely ill and admitted. We have chosen to do this testing on a batch testing. Our physicians seem to be very happy with waiting up to and usually less than 24 hours for this result, especially considering it used to take a week to get these results back. So currently our physicians have not asked that we put this testing at our hospitals or in the clinic, so it works better for us to batch it, save on some of the controls that we're using, and batch it at our regional laboratory. But certainly, depending on your patient population, depending on the acuity of your patients, it certainly could be something that you could use as a more random access type assay if you would choose to do that in your hospital setting.
Okay, thank you, Dr. Sharp. We have another question. What benefit of illumigene do you feel has contributed most to improving patient care?
Well, for us, it is definitely the more rapid turnaround time. That and the higher sensitivity of the assay. We know compared to culture and DFA that the molecular assays do have a much higher sensitivity. We get much less false positive results, as we know we get with culture and we get with the DFA. So it's really both of those things. We have a much more sensitive assay, and we have a much reduced turnaround time. And as I said in the presentation, that leads us to be able to report out an accurate rapid diagnostic much sooner than we could before, and allows the physician to give the patient appropriate antibiotics that hopefully will do 2 things. Not only allow the patient reduce symptomology and recovering from their disease faster, but also allow the patient to be on the right antimicrobial so that they're less contagious and less infectious for spreading that disease around. It also, the more rapid diagnostics also allows our infection control and epidemiology folks to do that case contacting of who might have been exposed to pertussis and get those people on appropriate post-exposure prophylaxis, again, so they don't develop the disease and, again, pass around pertussis as well.
Okay, thanks, Dr. Sharp. We have a couple of questions related to that previous one. Did you see an increase in prevalence rate when converting to a molecular test?
Oh, absolutely. As I said, the sensitivity of the test is much better than what we had before compared to culture and DFA testing. Again, as I said, our state laboratory did switch to PCR testing before we switched over, so the sensitivity that we were getting back from the Oregon State Public Health Laboratory was much better since they switched to the PCR assay as well. But again, we could felt that with this FDA-approved assay, simple assay, that we could actually bring the testing in-house, do it less expensively, and continue to decrease our turnaround time to results. Thank you.
Okay, and another question related to that. Can we still do the test even though none of the physical symptoms are evident, like cough or fever? This happens when an unexpected outbreak occurs. Doctors will order the test to all exposed people without symptoms.
Yeah, that's probably not an appropriate use of any diagnostic test for Bordetella pertussis or whooping cough. Again, keep in mind when we showed the slide about when you were able to actually potentially get the organism out of culture and or from molecular testing, the person does have to have symptoms at the time. So testing asymptomatic people who may have been exposed is not appropriate use of any kind of Bordetella pertussis testing. Certainly doing post-exposure prophylaxis, that is the way to go. Testing asymptomatic people is not appropriate.
Okay, we have another question. How would an adult know whether or not they should be tested for pertussis?
Yeah, that's an interesting question, because oftentimes in adolescents and adults as well, during that initial catarrhal stage of the disease, the first 2 weeks, again, it can be very nonspecific symptoms. It can, like I said, runny nose, puffy eyes, a little bit of coughing, but not the severe paroxysmal coughing that we see in the second phase of the disease. So it can be very nonspecific. It can just seem like you know, an upper respiratory infection, a head cold, if you will, and not turn into anything more significant than that during the catarrhal stage. But once you get to the paroxysmal stage, it becomes more evident that it is pertussis. So it is difficult during the first week or two of disease, sometimes when the symptoms are not classic, and oftentimes they are not, to diagnose Bordetella pertussis. So there has to be probably some kind of a giveaway that there's something going on. Is there a current outbreak going on in the area? Has the person been exposed to unvaccinated people that could be transmitting the disease? Was there anybody else in the family or anyone else they came into contact with that were having similar symptoms that went on to develop a more severe paroxysmal type of disease? So, as you know, head colds are very common all times during the year. So it can be very difficult to diagnose pertussis during the initial stage, during the catarrhal stages of the disease early on, especially if the symptoms are not classic, and oftentimes they cannot be.
Okay, thank you, Dr. Sharp. Another question. Are there any other respiratory infections that you typically see present with pertussis?
You know, that's a very interesting question. Our assay, again, using the illumigene platform, only tests for pertussis. So if we're having specimens come in for pertussis testing, we would know if there was something else there. If we get a negative pertussis, what was actually causing the patient's disease. We're not doing a multiplex assay. Some of you out there may be doing some multiplex assays. There are some multiplex assays out there that will detect other forms of respiratory diseases and other viruses along with Bordetella pertussis. So people that are performing that assay may be more able to answer that question. Pertussis, right now, we looked at our data. Our pertussis over the wintertime is much less prevalent than it is during the summer and the fall. Seems like we have more in the spring, summer, and fall than we do over the winter season. So it seems like in the winter season, influenza and the rest of the respiratory viruses kind of nudge out pertussis. We don't see a lot of pertussis testing. Currently, during the wintertime right now, we're seeing a very low percentage of pertussis positivity. Again, our positivity rate is higher in the non-winter seasons.
Okay, we have some other questions. The next one, do you test on all ages or pediatrics only?
No, thank you for the question. We allow all testing. I will say most of our patient testing is in pediatrics. When we brought up this test and we basically worked very closely with our pediatric infectious disease staff in order to bring this testing up, because it was felt that a majority of the testing would be done in pediatrics. However, we do allow the testing in adolescents and adults as well. Some of you may be familiar with the fact that here in the Northwest, we do have quite a few people that do not believe in vaccination, so they're not vaccinated, or if they've been vaccinated, their vaccinations have waned and they don't believe in vaccinating their children. So we do have probably more than our share of our periodic outbreaks of Bordetella every couple of years in our patient population up here that have not been vaccinated. So due to that, we do allow it to be done not only in our pediatric population.
Okay, thank you, Dr. Sharp. We have another question. What advice do you have for smaller volume labs to get physicians on board with adding testing in-house?
Well, I think what you first can do is you can discuss with your physicians and say, you know, there's an assay out there that we can do, and we can give you an answer to if your patient has, with very high sensitivity to know whether your patient has pertussis within 24 hours of the sample reaching the laboratory, as compared to waiting for that testing to come back from the public health laboratory or from a referral laboratory, which can take 3 days, or look at your own data, see how long that takes. I don't think you would find it a hard sell at all, especially with your pediatricians, to say that, you know, if we offer this test in-house, we can turn around this assay for you for all the reasons that I've gone over, for appropriate therapy, for decreasing infectivity, for case control contacts and post-exposure prophylaxis, et cetera. I don't think it would be a very hard sell at all if you could actually, you know, get the data on how long it takes you to get your test back now, know what your reference laboratories are using. Are they still using DFA and culture? Have they gone to a PCR-type assay? And even if they have gone to a PCR-type assay, which will have a much better sensitivity, again, the turnaround time is very important as well. So I would get that information together from your reference laboratories, what assays they're doing, what is your turnaround time from your reference laboratories, and then go to your clinicians, your pediatricians, and tell them, if we brought this test in-house, we could better the sensitivity by this amount compared to culture and DFA, and we can better our turnaround time by this amount. I don't think it would be a very hard sell. That's the way I would approach it.
Okay, thank you, Dr. Sharp. We have time for a couple more questions. Next question, you said your prevalence rate increased. Did the number of pertussis requests change as well?
I'm sorry, could you repeat that one more time, Sarah?
That's okay. You said your prevalence rate increased. Did the number of pertussis requests change as well?
That's an interesting question, and I have not looked at that data. What I would suspect is that probably a couple of things happened. Our pertussis rate did go up, and that's probably due to the better sensitivity of the assay that we were using. And I would suspect, you know, once information gets out there that you are offering a test that can be acted upon, you know, appropriately with the patient in the next 24 to 48 hours, physicians may tend to order the test more frequently. So that's a really interesting question, and thank you for that, because that's going to make me go back and look at our specimens that we were getting in to see if, in fact, our volume did increase as well. I would suspect it probably did. That's a good question, and thank you for that.
Okay. We have time for one more question. Are you seeing that doctors are ordering pertussis tests when presenting these minimal symptoms within the beginning stages, or would that be done in a follow-up visit?
That's a good question, too. And I will tell you, we have a really very good pediatric infectious disease group here in the Portland area, and they're quite astute and quite tuned into what's going on with pertussis in our area. Again, we do have a significant population in our areas that do not believe in vaccination. So they're very attuned to the fact when they see some of these patients in the area that they could be dealing with pertussis, because they know the feeling of their patients and vaccination. So I think our pediatricians up here, again, are very in tune to the fact that they're dealing with patients that may not be vaccinated. They're very in tune to the fact that those are the patients that they need to suspect Bordetella pertussis from more frequently, and certainly they know when there's an outbreak going on or a start of an outbreak going on, that's very well publicized in our area, as well as knowing that we see much more pertussis in the non-winter months. So again, our pediatricians are very attuned to what patient populations they need to look at.
Okay, thank you, Dr. Sharp, and that's all the time we have for today. So I want to thank you again, Dr. Sharp, and thank you to all of our participants for joining us today. We hope you found this webcast presentation very informative, and this concludes our webcast. You may now disconnect and have a great day. Thank you.